Welcome back to the deep dive. Today, we are going on a journey that is, well, it's a little bit internal. We are looking at a medical condition that affects a massive chunk of the population as they get older. And the wild part is most people have absolutely no idea it's happening.
Right. It's one of those silent phenomena of the human body, strictly an internal affair, until, of course, it isn't silent anymore. And when it breaks that silence, it demands immediate attention.
Exactly. And just to set the stage for everyone listening, we are pulling the insights for today's conversation directly from Dr. G.S. Raj's YouTube channel. He has some incredible visualizations that we are going to try and, paint for you with words today, specifically focusing on the colon.
The topic at hand is diverticulosis of the colon. And it's a perfect topic for a deep dive because it combines anatomy, geography, and some pretty high-stakes surgical decision-making.
Diverticulosis. Okay, let's unpack this right away because I feel like I hear two words thrown around constantly and people use them interchangeably. I hear diverticulosis and I hear diverticulitis. Are these just synonyms or is there a distinct difference we need to know?
That's a great question. And no, they were definitely not synonyms. There's a fundamental difference, and understanding that is really the key to the whole topic. Think of diverticulosis as just the condition of having the anatomy. It's the presence of the outpouchings.
Okay, so just having the pockets, that's the osis.
Precisely. Whereas diverticulitis, with that itis suffix, that's when those pockets start causing trouble. It's the inflammation.
Ah.
So osis is the structure, itis is the fire. You can't have the itis without the osis, but you can certainly have the osis without the itis.
Got it. So our mission today is to basically take a tour of the colon. We want to understand the geography of where this happens, what it looks like, and then, maybe most importantly, break down the system surgeons use, the Hinchey classification, when things really go wrong.
And that classification system is fascinating because it's really a roadmap for decision-making. It tells the surgeon whether to reach for a prescription pad or a scalpel. But let's start with the basics, the anatomy.
Let's do it. So what exactly is a diverticuli? When we say outpouching, what are we actually looking at? Is it a growth? Like a polyp?
No, it's actually the opposite. It's a herniation. A diverticulum is essentially a mucosal herniation. Imagine the wall of the colon. It has layers. You have the strong muscle layer on the outside and the soft lining, the mucosa on the inside.
Okay, muscle on the outside, soft lining on the inside.
Correct. Now, if there is a weak spot in that muscle wall and you have pressure building up inside the colon, that soft inner lining, it pushes through the muscle. It bubbles out.
I'm trying to visualize this. It's almost like, okay, imagine you're wearing a pair of pants and the pockets are turned inside out, but instead of flopping out, they are pushed through the fabric.
That's a decent analogy. Or think of an old bicycle tire. If the rubber wears thin in one spot, the inner tube starts to bubble out through that weak point. That bubble is the herniation.
Right, the bubble on the tire. That makes perfect sense. And when we talk about diverticulosis, you often hear doctors describe these pockets as bland, which I have to say is a very funny word for a medical condition.
It is, isn't it? Bland usually describes, unseasoned food. But in medicine, bland is beautiful. It means uninflamed. It means that there's no redness, no angry swelling, no infection. It's just there. It's a structural change, not a disease state yet.
So if I have bland diverticulosis, my colon just has some extra architectural features.
Exactly.
Now here is where it gets really interesting to me. The source material brings up this demographic split. It seems like where you live, or maybe your genetic background, actually dictates where these bubbles form.
This is one of those facts that really highlights how diverse human biology can be. There is a very, very specific contrast between Western populations and Asian populations.
So lay it out for us. If I'm in the West, what's the typical profile?
If you are looking at the majority of the Western population, these outpouchings tend to develop as people reach their 50s and 60s. It is very much an age-related remodeling of the gut. And geographically, within the body, they are almost exclusively found on the left side.
The left side.
So typically, the descending colon and the sigmoid colon. That's the last stretch of the colon before the rectum. That's where the pressure dynamics seem to affect Westerners most.
Okay, so 50s, 60s, Western world, left side. But the source says it's different for Asian populations.
Completely different. In Asian populations, there is a stark contrast where diverticulosis often appears on the right side of the colon, the ascending colon.
That is wild. It's the same organ, same function, but the geography of the defect flips sides based on the population.
It really is fascinating. It challenges the idea that our anatomy is just a standard template. There are these regional variations that physicians have to be aware of.
Right.
I mean, think about the implications for diagnosis.
Yeah, because pain on the right side usually means one thing.
Exactly. If a Western patient comes in with right-sided pain, a doctor's brain immediately screams appendicitis. But if an Asian patient presents with that same pain, the doctor has to pause and think, wait, this could be right-sided diverticulitis. The context changes everything.
So we know where they are. Now I want to know what they look like. If we are doing a deep dive, let's go inside. If a doctor is performing a colonoscopy or a sigmoidoscopy, what are they seeing on the screen?
The visual is quite vivid. Imagine you are guiding the endoscope, the camera, through the sigmoid colon. The walls should be smooth, but instead you start seeing these openings. They look like craters.
Craters, like pockmarks on the moon.
Exactly like that, outpouchings, and they vary in size. You might see small ones, barely a dimple, or medium ones, or even very large outpouchings that look like caves. It's not uniform.
And are they empty, or is stuff getting stuck in there? Because if it's a pocket in the gut, I imagine it catches things.
You are spot on. Some of these pockets are completely empty, just open caves, essentially. But others are filled.
Filled with what?
Fecal material. The technical term is fecaliths.
Fecaliths. That sounds geologic, like a stone.
That's essentially what it is.
Mm.
Lith means stone. It's hardened fecal matter that has become trapped inside that herniated pocket and compressed over time.
Okay, that sounds like a recipe for disaster. You're walking around with pockets in your colon filled with hardened waste stones. That has to be painful, right? I mean, I feel a pebble in my shoe immediately.
You would think so. But this is the aha moment for this condition. The majority of the time, these even the ones with the fecaliths inside, do not cause any symptoms.
Right.
Really, you could be walking around right now, fully functional, feeling great, and have a colon that looks like a pockmarked moonscape filled with little stones. As long as it stays bland, as we discussed earlier, your body doesn't register the pain.
That is the part that always gets me. The body's ability to just tolerate these structural failures without complaining until it stops tolerating them.
And that is the perfect transition. Because eventually, for some people, the truce ends. We cross the line from diverticulosis to diverticulitis.
The itis, the inflammation.
Exactly. The silence is broken.
So what triggers that? What does that turning point look like inside the body?
Well, imagine that bland pocket we described. Maybe the neck of the pocket gets blocked by that fecal stone. Pressure builds up. Bacteria starts to multiply in that closed space. Now, instead of a clean, open pocket looking through the camera, you see a diverticulum that is extruding pus.
Oof, extruding pus. That is a visceral image.
It is. And it's not just the pocket itself. The surrounding tissue reacts. You see visible inflammation, intense redness, and significant swelling in the area around that pocket.
And I assume that swelling takes up space.
It does. The lumen, which is just the medical term for the open tube of the colon, actually becomes smaller. The walls swell inward, narrowing the passage.
So we've gone from bland pockets that are just minding their own business to infected pockets extruding pus and swelling the colon shut. That is a massive escalation.
It is a critical medical event. And this is where the surgeon's brain has to kick in. Because once you have diverticulitis, it's not just a binary yes or no situation. It's a spectrum of severity.
Yeah.
And we need a way to grade that spectrum.
And this brings us to the Hinchey classification.
Correct.
I love names like this because it sounds like a detective solving a crime, but really it's a surgeon deciding how to save your life. What is the Hinchey classification?
It's the standard system surgeons use to grade acute diverticulitis. It helps them decide the strategy. It answers the question, can we treat this with medicine and observation, or do we need to operate immediately?
Okay. And what are the factors? What are they looking for to determine the grade?
They are looking at the extent of the inflammation, whether an abscess, a collection of pus, has formed, and crucially, whether the pocket has ruptured, which we call a perforation.
Ruptured, like the tire blowing out completely.
Exactly. The containment fails.
Okay, let's walk through the stages. There are 4 of them, right?
Yes, 4 stages. Let's start with stage 1. In stage 1, the infection has caused an abscess to form. There is pus. But the body has managed to wall it off. It is contained and limited to the mesentery.
The mesentery. We should probably define that for the non-medical listeners. It sounds like something from architecture.
In a way, it is. Think of the mesentery as the scaffolding or the tissue that attaches the colon to your body wall. It supplies the blood vessels. So in stage 1, the pus is trapped in that fatty tissue right next to the colon. It hasn't spread far.
Okay, so stage 1 is bad, but it's local. It's contained.
Right. Now, stage 2, the abscess has grown bigger. It has
Right.
overwhelmed that local containment. It's no longer just hugging the colon and the mesentery. It extends down into the pelvis.
So it's taking up more real estate.
Exactly. It's a larger collection of infection sitting deeper in the pelvic cavity. But, and this is key, it is still essentially an abscess. It is a pool of fluid that is distinct from the rest of the belly.
Okay, so stage 1 is local, stage 2 is pelvic and bigger. Now we get to stage 3. And I feel like the music changes here. The stakes seem to jump.
The music definitely changes. Stage 3 is a critical escalation. This is where we have free perforation.
Free perforation, that means the containment is gone.
Yes. The pocket has ruptured open. And in stage 3, pus is no longer inside an abscess. It is contaminating the entire peritoneal cavity.
The abdominal cavity, so essentially the infection is loose inside your belly, washing over your other organs.
Correct. It's generalized purulent peritonitis. The entire abdomen is inflamed because of the pus.
And stage 4, how can it get worse than pus everywhere?
Stage 4 is also a free perforation,
Yeah.
but the contaminant changes. In stage 3, it was pus, which is fluid from the infection. In stage 4, there is free perforation and fecal matter enters the peritoneal cavity.
Oh, wow. So actual waste is spilling into the abdominal cavity.
Yes. And as you can imagine, the bacterial load there is off the charts. The risk of overwhelming sepsis with fecal contamination is the absolute worst-case scenario. It is an immediate threat to life.
That is terrifying, honestly. So just to recap for everyone, because this is the surgeon's guide, stage 1 is a contained abscess in the mesentery. Stage 2, it gets bigger and goes into the pelvis. Stage 3, the dam breaks and pus spills everywhere. And stage 4, the dam breaks and fecal waste spills everywhere.
That is a perfect summary.
So knowing that, how do they treat it? I have to assume stage 4 isn't something you just take a pill for and sleep off.
No, absolutely not. The Hinchey classification splits the treatment strategy right down the middle.
Okay, let's start with the worst one, stage 3 and 4.
For stage 3 and stage 4, because of that free perforation, because you have pus or fecal matter loose and the belly surgery is required, you cannot leave that material inside the abdominal cavity.
Right, you have to go in, clean it out, and fix the hole.
Exactly. It's an emergency intervention. Usually this involves removing the diseased section of the colon and washing out the abdomen. There is no waiting.
What about stage 1 and 2? Those are the abscesses. Do those need surgery?
Generally, no. This is the medical territory. These stages are often managed medically. The primary treatment is antibiotics.
Just antibiotics, even for an abscess.
Often, yes. If the antibiotics can kill the bacteria, the body can reabsorb that fluid over time. It's the path of least resistance. However, there is an intermediate step for the larger abscesses, especially in stage 2. In some cases, they might request interventional radiology.
What does that involve? Is that surgery?
Not in the traditional sense. They don't cut you open. They use imaging like a CT scan or ultrasound to guide a needle and a tube precisely into that abscess. They place a drain to remove the abscess fluid physically.
That's amazing. So they can drain the pressure and the infection, let the antibiotics work, and save the patient from a major operation.
Precisely. It turns a potential surgery into a minimally invasive procedure. It cools everything down.
But here's a question. Let's say I have stage 1 or 2. I take the antibiotics, maybe get the drain. I recover, the inflammation goes away. Do I still have the diverticulosis? Do I still have the pockets?
Yes, you do. The anatomy hasn't changed, just the infection status. You've gone back to the bland state we talked about at the beginning.
So are you just a ticking time bomb? Does the surgeon come back and say, hey, let's take that part of the colon out before it happens again?
That is the million-dollar question. This is where the surgeon plays the long game. Once the patient recovers from the acute attack, specifically those who are managed medically for stage 1 or 2, the surgeon then has to evaluate the big picture.
It's not automatic.
No, it's not automatic. It's an elective surgery decision. They look at the timing. They look at the patient's overall health.
Because surgery itself has risks.
Exactly. If you are 85 with a heart condition, maybe living with the pockets is safer than undergoing a major bowel resection.
Yeah.
But if you are 50 and healthy, and this is your second or third attack, maybe they say, let's fix this permanently while you are healthy. It's a very nuanced conversation.
It really emphasizes that medicine isn't just fix the problem, it's manage the risk.
Always. It's about weighing the risk of another attack against the risk of the operating table.
This has been such an eye-opener. I think we tend to think of our guts as just these tubes that process food, but the complexity, the staging, the anatomy, the way it changes with age is incredible.
It is. We went from understanding a simple herniation, a pocket in the wall, to seeing how that simple structural flaw can escalate into a life-threatening stage 4 perforation.
And the fact that geography, plays a role, that my colon might look different than someone's in Asia, is something I'm not going to forget.
It's a great reminder of the diversity of human anatomy. We aren't all built exactly the same.
Before we wrap up, I want to make sure we give credit where credit is due. This entire deep dive, the definitions, the Hinchey stages, the visualizations, all of that came directly from Dr. G.S. Raju's YouTube channel.
Yeah,
It is a fantastic resource if you actually want to see the things we described today.
absolutely. The clarity Dr. Raju provides on that channel is invaluable for understanding these pathologies.
So what's the final thought? What should we leave our listener with today as they go about their day, hopefully with a very happy colon?
I think the provocative thought here is about our internal landscape.
Hmm.
We tend to view our anatomy as static. We think, I have a heart, I have a stomach, I have a colon, and they stay the same. But diverticulosis teaches us that our internal geography is dynamic. It changes with age. We develop new features, new hills and valleys, or in this case, pockets and craters, completely silently. We are constantly evolving on the inside, often without a single signal reaching our brain, until that one moment of inflammation demands our attention. It makes you wonder what else is shifting inside us right now that we just haven't noticed yet.
A little unsettling, but fascinating. Thank you so much for breaking this down with us.
My pleasure.
And thank you to everyone listening. We will see you on the next deep dive.